perhaps we could start. So when people come in, they can jump into the topic. And welcome to the research day of our meeting. As I said, if you were present on Wednesday when we started, this is a regular way of having our meetings, that we focus one day on research on different elements what the people want to focus on. This time we have a more or less a ready-made program with hopefully very interesting presentations. And I'm very glad to have Anders LINDSETH with us now. Anders is a professor in philosophy, professor in, or how do you call, emeritus, no longer actively involved in the university. But please close your microphone when you... But Anders really has been the resource for our network from the very beginning. So that Anders with John Schotter were the two guys who were guaranteeing the high philosophical quality of our meeting, if I would use that word. And Anders still is willing to go on, and that's I'm very happy about, because these meetings were from the very beginning, as we thought with Tom Andersen, to intertwine, to combine the idea of research and developing clinical practice in the way that Tom Andersen was very focused and very strongly, first come practice, then come research. And of course, this is the idea to make use of the research also, to how could we understand more about the clinical practice in research. So when we start, perhaps Anders, you would be willing to say some words about yourself and what would you like to say, and then I have a very small presentation about some examples. What is the role of research in developing open dialogues?
Yeah, I could say a few words that could be a kind of introduction to your presentation then, JAAKKO.
Good.
And what I would like to say is that when we talk about research in medicine, in the medical context, we usually think that research is about the effects of the treatment of a disease. You think you have a disease and you should have a treatment of that disease, and the question is how effective, how is it, do this treatment work or does it not work? But that's a big problem in psychiatry, because it's very problematic to say that psychiatry is about diseases, because in somatic medicine, if you have a disease, you normally are able to measure, to have some measuring, telling you what kind of a disease it is. But in psychiatry, you cannot measure anything. You have a description of a symptom picture. You describe symptoms and you get the picture of that, and you gave this symptom picture a name, and that is then the disease. And that is a very problematic concept of disease, and it is very problematic to do research what kind of treatment can be effective for handling such diseases. So I think what we are going to talk about today is that one should regard problems in psychiatry as crisis. We all come in life into crisis, and there are severe and not so severe crises in life. And psychotic crises are rather severe crises, and then it is so important to come in early in the process of such crisis, and the dialogue and all that what you are going to talk about now, JAAKKO, is extremely important. And what is the challenge for research is to describe this process. It is not to come up with measures for treatment of a disease, but it is about describing how to relate to a certain kind of crisis that we call psychotic. And by doing that, it is possible to understand something. So this might be important. It might be important to come in at once or very early in such a crisis. And if you tell people, oh no, you have got a severe disease and the specialists for that are very occupied, so it will take a week, 2 weeks, a month until we can treat you, that is the worst thing you can do, because then you are guaranteed that it will get worse. So that was just what I wanted to start by saying, and I think it is obvious, but it has to be said many times, I think. So that as a kind of introduction to your presentation of the principles and the research you have had, JAAKKO, by investigating this open dialogue approach to psychotic crisis. Yeah. So far.
Thank you. I will start by sharing some slides. I hope did this slide change or not? Do you have only one slide or do they change also? Because sometimes it's problematic.
I see the first picture.
And now, do you see the first still, or?
I see still the first.
We see the whole, JAAKKO, you should press F5. We see the whole, it's not full screen. We see the other one, but it's okay.
Okay, now I will use this format. Yes, so I will speak about the research in, as I have named it, a naturalistic setting or in the real world. And one idea of doing this research is to do the research for developing the practice. In what we were up in the first meeting about the problems with very thin idea of the evidence-based medicine, it's more or less the opposite, because there is the idea to have the research to inform how effective the research is. And in this naturalistic design, for me, it's really the idea of the research is very different. The evidence-based medicine research is a very problematic, and I have taken one slide of the very prominent evidence-based medicine researchers. For instance, here's one of the author is Finnish guy called Jyri Tiihonen, and Robert Whittaker usually says that Jyri Tiihonen is the researcher in the world who is mostly occupied of propaganda for medication in his research. But some 10 years ago, they even with Taylor and other published a paper in which they actually said very openly that this randomized clinical trial, that is the basis of having treatment recommendations, are very problematic. And they say that you cannot make generalized conclusions in this measurement, and because they do not stand for the real world, especially because of the high dropout rates, short trial duration, and the selection bias in patient required recruitment if they are taken into account. For instance, in the medication trials, it could be the 70 to 80% of the people who start the program will not end, and the conclusions are made with very few cases, and having a larger multi-center studies is of course, it's a very expensive and very problematic. And they actually say that you cannot rely on the results of the randomized clinical trials in many risk groups. Especially you cannot do generalized conclusions about that. And this is very known in all research, which says that 20% of the efficacy of the analyzed method is lost when it put into practice. So if you have some results for medication in depression that says that 50% of the people could have better because of this medication in this trial. But then if you take that into the real world in your practice, the number is 30%. So 20% of the efficacy is lost. And this is openly agreed in the research world. But still, the recommendations of the treatment are based on this kind of research. But thinking the research in naturalistic design is very much different. We do not construct artificial realities, but we go and look at what happens in the real world and not in the laboratory. And this is strong emphasis on something that we call on external validity. Again, some researchers in the clinical trials, they say that they do not have interest on the external validity. They have more interest on internal validity and the reliability of the results. And for me, the external validity is most important. If the results really stand for the real world in which we are doing our clinical practice. For that reason, for me, for instance, having the placebo trials or randomized trial in medication research in psychiatry are very problematic. I wouldn't do that because the results, when you are a doctor, you really do not never prescribe the same medicine, the same dose for all of your clients. And this means that the design of any research is constructed based on the specific context and specific methods of research. And also what is very important that we do no longer do a distinction between quantitative and qualitative research, but in the research world there is used this concept of mixed methods so that it's best information and best validity of the information is reached when you really are doing the both. You can do some measurement in the statistical way, but of course it's very important to make some investigation about what does it mean, for instance, in one single cases. And very simple way, if we think of this type of work as open dialogue or other interactional therapies, I mean forms of psychotherapy or other forms of therapy that are not based on some manual that you need to follow step by step, but are based more on the interaction that we have with our clients. And in these 4 steps, you, for instance, could have a good information about what is happening. First, you need to have some follow-up of the outcomes. You can make very easy ratings of something. You can make a register of the disability allowance days or whatever are the outcomes you want to measure. And of course, it's very important to have some kind of comparison to know if these outcomes are especially in this system or in other system. In the second step, you can then, when you have the information of the outcomes, for instance, in what is said in the tree, you can have a comparison with the cases in which the results were not so good compared in which the results were optimal. So you can choose specific situation to make an inquiry about the system in different form, and then make a comparison of what is the difference between those who had a good outcome and poor outcome. In my mind, I suppose that this is the most powerful explanation, much more powerful than having a group mean comparison that is done in the randomized clinical trial. And then last point, to integrate the outcomes to the statistical information that we have, integrate the ideas that we have found out, for instance, in single case studies to the statistical data and a comparison of groups.
Could I say a little thing? When you talk
Please.
about validity,
Yes.
I will say as a validity is about, so the question of validity is the question, do you investigate what you say you investigate?
Yes.
And what also in randomized controlled trials, people doing that, they say they are investigating the causes of effects.
Mm.
So a special treatment by medication or something should have effects, and you have to, and you are investigating this this causes, so that should cause certain effects. But and that is the, I think that is the internal validity. So this this cause-effect connection. But it is very problematic because there are so many variables you can't control in such experiments. So you can't really know what is the cause for the effect. It is they do as if you could find it, but you don't really find it. And as you say, there are many dropouts and there are many things coming in that makes it very difficult. But what you call external validity, that is something you can understand. You can understand that if we work in this way, we can see it has effects in cases. And then you can understand, that is working. And that gives a good outcome. But in this case, the outcome was rather poor. Then you may understand why it was poor and not good. So that is a very different way of doing it. It is not the attempt to do as if you had a treatment method that should work in all cases, and if it don't work, you have to have another treatment method. This is a way to behave, to relate to life crisis, and you describe how to relate, and that is understandable, and you can learn things from that, and that is a way to go on. So it is so strange that this medical world.
One of the arguments that those people who are for this treatment of excellence guidelines, for instance, treatment of excellence guidelines in schizophrenia, I think that almost all countries have something like that. And then the outcomes are very poor. And then they say that, for instance, when I criticize that, that there you see that this kind of treatment focusing on medication do not affect. I will show some example of that later. And they say that, yes, but it's because the people do not follow the rules that we have there. And the follows are impossible to follow. The rules are impossible to follow. That's the idea, because they are so strange. They describe so artificial reality that it's impossible to follow those rules in the real world. Okay, I will give you some examples of the studies that we have done in Western Lapland in respect of open dialogue. And I many times said that because this research part also we started to prepare our first studies 87, how much is 35 years ago. And this small province in Western Lapland, it's probably the most scientifically analyzed psychiatric system in the world, because I have never seen any other. In the very first study, we had an interest to look at what happened on the boundary between the hospital and the family when one member of the family is referred to the hospital, and we had started to have the practice. We decided that we will have the first meeting before the decision is made to admit in the first day immediately. And then we found out in this follow-up that there were big differences between those who came for the first time in respect with those who had a reoccurring crisis, and thirdly, those who had a long history in psychiatric care. And that was, of course, very important notions as such. For instance, in the first crisis, families were very motivated. You really need to be very skillful to avoid families to be part of the treatment because they are so scared and so motivated about the system. We found out that teamwork was the way to open up the interest of the social network. And when we made a comparison of single doctor making admission interview, that was only focusing on the symptoms and the issues, and it was not possible to focus on the social networks. These were the first ideas to introduce the importance of dialogue. And we really, for instance, had a conclusion that it's not good to try to force the family to accept the home treatment instead of hospitalization. This treatment had a huge effect of the system. We realized that we could reorganize the system, declining the number of hospital beds, and organize home treatment teams, crisis intervention teams. And also we started to have some ideas how important it is to follow the ideas and ways of life of the families and the client. The second very important study or group of studies has been this three period of including people who have first psychotic crisis in the team in their life. First one 92 to 93, that was part of the Finnish national project integrated treatment of acute psychosis because of very surprising results in respect, for instance, that only so few needed medication in the beginning because it was proposed not to start the neuroleptic medication, and it's only less than 20% were medicated in the beginning. And the outcome seems to be very good in respect of the expectation. And then we decided to go on with our own study, Open Dialogue in Acute Psychosis. And 10 years after the first study, we repeated the same idea, a bit not so scientific orientated, but more clinically orientated. And with all these who have been included in the three groups, there has been long-term follow-up with 19 years, and now lately there are many resist-based studies, and we make a comparison with those who have the treatment of open dialogue in Lapland compared to the rest of Finland. Finland is a very good place in this because there are pretty good national registrations of, especially of the use of services of the mortality. Not always so reliable, but still possible to do. And I will come back to this. I will show some results of this psychosis research. But the second big project was that was led by Professor Jukka Aaltonen, 94 to 97, when 94 to 96. And when we already had the new system of care that we're focusing on mobile crisis intervention, and Jukka Aaltonen got an interest to organize a research in which we wanted to understand what happened to the clients in the new system. And we made a qualitative content analysis of the 3,000 patient records, all the people who had taken first contact during 10 years period of time, and followed in the journals 2 years time of their treatment. As a conclusion of that, we found out that the incidence of schizophrenia is declining very rapidly, and also we came out to found the optimal elements of care. I will need not to go to this that we now call as main principles of open dialogue, but only to emphasize that these ideas were outcome of a very systematic study. And in this way, again, the research has been very essential to understand the ideas. Of course, coming into the conclusion is these optimal principles made also possible to introduce this to the rest of the world, that we have found this in our system, and perhaps some elements of this could be interesting for all of us, as I think. But of course, there are also some specific elements to the Western Lapland. At that time, 95, we also were thinking, how would we name if we have some name for this system? And we came into the conclusion that perhaps we could call this as open dialogues. Opens in the way that it's based on open meetings in which all people can participate, and it's focusing on dialogues and not for solving problems or making plans or something like that, but really understand more about the life that has happened. Then some information about these psychosis studies that has been so important. As I said, we had three inclusion period of first-time psychotic patients. One idea of this that Western Lapland is a very small province, and of course there are not so many. Even if you would have a high incidence of schizophrenia, there would not be so many psychotic patients. And in this respect, having the possibility to have repeated measurements, repeated analysis is of course good. In the first national research part, we could 33 patients that were included, and there were 39 in the intention to treat group, but 6 did not follow. The mean age was, sorry, there is a failure. It would be 26 years of age. 64% had a diagnosis of schizophrenia. And very short information, 26% were using neuroleptic medication in this 2 years period of time, and 84% had returned to full employment or job seeking. We knew, of course, at the moment already that this is very different outcome compared to the system of care usually. And as I said, we decided to have our own project to look more deeper, and 94, 97, we had this open dialogue in acute psychosis project in which we included 42 patients out of this 51 who came into the treatment. There had been some decline in what we call the diagnostic criteria to schizophrenia. People used neuroleptic about the same. There were some less on medication, and even some better outcome of the system. We could also say that this period of time, 94 or 97, was a kind of a period of time in which we already have a full acceptance of the principles of open dialogue, whereas the previous period was kind of a rehearsal of understanding about more. Then 10 years after, we started actually part of what we call multi-center study in our network that we have meeting now, but the other sites did not manage to have the information so much. We decided to do our own analysis and about the first-time psychotic patients, and we realized the outcomes were very much the same. There were some interesting differences. They were younger, who came into the treatment 10 years after. And it also described that many of these people did not have so explicitly defined psychotic symptoms, but much more a kind of sensing of something. It also meant that many of them did not continue after 1 or 2 meetings, and that's why we had 27 people who were proposed, and only 18 came involved into the research. But the outcomes are more or less the same. Then we combined all these, and Tommy Periström has been the researcher to principal investigator in this, and we made a comparison of the register-based information to the rest of Finland. Robert Whittaker already yesterday showed these results, and we found out some differences in the mortality rate, but when we controlled the age, there were no longer differences. As you saw that in the third period of time, the age of people who came into the treatment, they were younger. But there is a huge difference in number of hospital days. Ongoing contact still have in the system of care 50% compared to 28% in this open dialogue Western Lapland. On medication, we're 80% compared to 36%, and on disability allowance 61% to 33%. There are two things that I want to take up here. First, when you look at this treatment as usual, how is the situation in the mainstream psychiatry, you could think? This is about Finland, of course, but I don't know if there would be any difference. And for me, this statistic is quite terrible, because what it says is that when I came to this work in psychiatry, we were used to say that out of those who have schizophrenia diagnosis, 1/3 can recover, 1/3 still stay in the treatment, and 1/3 are chronified. And when we look at these outcomes of those who came 95 to 96 in the treatment as usual, they are almost the same. Nothing development has happened in the treatment as usual in 30 years, 25, 30 years. And no one is asking about this. How come? This is the period of time of these evidence-based medicine guidelines. And at the same time, we had an option here to come into this humanistic perspective. About these outcomes in Lapland, of course, it's very important to notice that after 2 years, there is no control of what kind of help people have received thereafter they have come into the treatment. So they may have been in traditional psychiatry also. Then there is in many of the studies, there is a very strong focus on dialogues, importance of dialogues. And what has been very important in our context in Lapland was the doctoral dissertation of Kauko Haarakangas, Voices of the Treatment Meeting. It's unfortunately published only in Finnish, but for the system, it was very important, especially to use in the trainings when Kauko was looking at what kind of elements are crucial in the meetings, in the open dialogue meetings, and what type of voices are present there. I had one study that for me was very important that was published 2002, in which there was a comparison between good and poor outcome in psychotic crisis, especially in respect of the quality of dialogue. And based on this research, some years after we developed, when we had a research project looking at what happened with the people in deep depression if their spouses are invited in the meeting. By the way, this was a randomized trial, so I have also done randomized trial in the naturalistic setting. And there we develop a method to look at the quality of dialogue, dialogical methods in investigation of happenings of change. And then 10 years before, we had a great possibility to look at the embodied part of the dialogue when we got funding from the Finnish Academy to look at this, look at the entire responses of 2 therapists and 2 clients in the meeting. This was called as relational mind. One outcome, some examples of these could be, perhaps I will say this and then I start to stop my part. For instance, when doing in the comparison between the good and poor outcomes, we found out, I found out, this was a study that I made myself by looking and analyzing video recordings on 10 good outcomes and then not so good outcomes. And we found out the differences, for instance, that in the good outcome situation, the clients could take initiative. How do we communicate? Whereas in the poor outcome, there was not such option present so many times. In the good outcome situation, there were a lot of a kind of symbolic language description, whereas in the poor outcome, almost nothing. This poor outcome situation where discussion of treatment and not of life so much. And there were most part were dialogical in the sequences in the good outcomes compared in not so many in the poor outcomes. I will look if there are some other parts that I would like to show. There are I will not go into the detail, but only examples how this information of the studies can help you develop your practice. For instance, in the psychosis study, when we made a comparison between the two first episode of times, we found out that that really the idea to have less hospitalization had succeeded. So both during the first 2 years compared to the years between 2 to 5 years, in the second period of care, the people were much less hospitalized, so that the professionals can really learn to tolerate the uncertainty and come out to the situation. As a very short conclusion about this, I have used this information to think about why the dialogical practice can be so effective, and with the 4 ideas, I think that when there's immediate response, we can meet all the people in the very emotional turmoil, which is very good meeting point. Then secondly, the social network, including the families, but also many times other are included, so the relevant part of the life is there. And then when we have a focus on dialogue, we focus on having all the voices heard, so that everyone who should have a feeling that they are respected. And in the very end, we can say that in this way we could have avoided the use of neuroleptic medication, and in this way to have avoided the harmful effects of the medication. You perhaps remember yesterday that Robert Whittaker was very concerned about the idea that you cannot have the good outcomes in open dialogue if you do not follow the new procedure of the selective use of neuroleptic medication. And I totally agree with that. This may be a very painful idea, but definitely needed if you want to have some outcomes like this that has become. And well, okay, I already said some words about this intertwined process of the care. So those were the examples of the how research has been part of developing the practice in Western Lapland. Anders, I wonder what.
Yeah,
your thoughts.
I think I would like to say a few words on dialogue, because that is something that we all know very well from our life experiences, how important dialogues are in life. So if we come into a difficult situation in life, some kind of a crisis where we don't exactly know how to go on, I think you could say that is a definition of a crisis, that you don't know how to go on. You realize if I go on as usual, it is getting worse in my life. That is a very old way of thinking crisis, and this crisis situation, there is always a possibility to choose a better way and getting out of this difficult situation. But then you need dialogue. And why is dialogue so important? Yeah, you could say, I think the most important in dialogue is that you realize you are heard, what you try to express, and you are taken seriously. You realize a kind of respect. And I think that is very important, to be able to listen to yourself, to take your own experiences seriously. And there is such a it's a tendency in medical treatment to think that the most important thing is what the wise guy is saying to the patient, what the doctor, what the psychiatrist is telling to the patient. That is the important thing. But probably it is more important that the patient is able to hear himself or herself. And because that is a precondition that your situation become less chaotic. And if you are not in a situation to be heard, to be taken seriously in dialogue, this inner chaos may be much stronger, much worse, and some people then, and it could happen to all of us, I think, that we then go into these processes that I think in psychoanalysis is described as primary processes. So where you could, to say it simply, you start to dream by being awake. And that is problematic. If you dream by being awake, people around you normally get quite upset. So it is so important if you then can express yourself to people listening to you. In many cases, maybe in absolutely the most cases, you can get out of this chaotic situation where you have to go into dreaming by being awake. And it is such a tragedy, I find, that psychiatry don't understand this importance. In psychiatry, you are in this medical model of thinking diseases. Oh, this is a severe disease, and how to treat it is very difficult, and we have few experts, and it takes long time, and in the most cases you don't even, so if you don't need a very educated expert to have a good dialogue. I can tell a story. I have a friend who was working in psychiatry as he was studying. And he was standing looking out of the window together with a young man who was a patient in the psychiatry. And this young man then asked him, "Tell me, are you educated or are you just working here?" And then my friend said, no, I am not. I'm just a student. This is a summer job I have here. Oh, that's good. Then we can talk together. Mm-hmm. So that's a good thing. Are you educated? Oh, thank God you are not educated. Then we can talk together. Yes. So dialogues should not be made too complicated. Yeah, JAAKKO, that was short.
No, it reminds me some years ago, one person started to call me. I never knew him. I have not contacted. He has found my name, and he described that he has put into the hospital, and he said that no one listened to me.
Yeah.
And I said, seriously, no one listened to me. Yeah. Yes, there was one, but she went into a vacation. And then later, or with my colleague, we found out that this one who had actually started to take a supervision with one in our team of a sudden of how to be dialogical, and this man immediately, among the 25 persons who were working there, realized that this is with whom I can speak and not. Also reminds me what you said by the idea of a very important Swedish professor, Johan Kullberg, who sadly passed away last year or year before, and was working a lot in this need-adapted idea of psychosis. Johan was a psychoanalyst, but he had an idea that he wrote in his book that people who become psychotic, they have a very strong tendency to heal themselves. And what is needed to become, not to disturb this process. And he repeated that it's much more important to ask what to not do instead of asking what to do. So please do not disturb the process, the natural process of healing, in which the system, I would say the embodied system, starts immediately when they see that something is wrong. And of course, this is to come to back what you said, that this is the question of dialogue, to let the people hear themselves.
Yeah, to Maybe I used too much time to stories, but as you mentioned, Johan Kullberg, I remember I told him the story as we met on one of these meetings that he found quite funny, and it is a funny story. It's a friend of mine who is a philosopher as myself, and he is doing what I'm also doing as a philosopher. We are meeting people, talking about life issues as philosophers, not as therapists. And this friend of mine, he had a lady who came to him who had a lot of diagnosis of anxiety. What do you call it? Phobia. And he talked to her, and after a while, she told that she heard some voices. Mm-hmm. And then my friend, oh, so you hear some voices? Have you told that to these psychiatrists you have visited? And then she looked afraid, and then she was quite upset and said, do you think I'm crazy? I would never tell a psychiatrist that I hear voices. And so that is a definition of being crazy. That is that you tell the wrong things to psychiatrists. So Johan Kullberg did find that very funny. Do you think I'm mad? I would never tell that to a psychiatrist.